thank you all for joining. Welcome to the first annual now Lee Jong-wook Memorial Lecture Series that we'll be doing. We have many folks to recognize and to celebrate with this, and the first of them, for those of you who do not know, that is Lee Jong-wook. He is an individual who was born in 1945. He got his medical degree in South Korea. And then he was, amongst other things, he took care of leprosy patients and was when you read his biography, was interested in public health. He worked at the WHO in varying different capacities, from sort of the entry level up into the Director General of the WHO for 23 years, starting in 1983 until his death in 2006. I believe, and John can correct me if I'm wrong, that when he was named to be the Director General, I think he was the first Korean person to be the head of a major international organization at all. So quite well known in Korea too. He unfortunately died in 2006 in Switzerland after surgery for a blood clot in his brain. But I just want to read you a couple of quotes from individuals about his contributions. The first was from Kofi Annan, who was the Secretary General of the UN, who said, "The world has lost a great man today. He was a strong voice for the right of every man, woman, and child to health prevention and care, and advocated on behalf of the very poorest people." You all have been sitting here for a while, so I think you've read the quote that's up there. I won't read it again. It's not advancing. So let me do this. There we go. And I think one of the reasons I wanted to include this slide, thank you, John, for providing all these slides, is that I think you'll recognize something that the type of advice you get from John Hess, too. You get a lot of common sense, real-world experience type pieces of advice, and he made a couple great comments about the public health. In fact, that the most important public health problem in the world today is the lack of the rule of law. And he emphasized that people in his country do not live in mud houses for lack of architects. I think those are some fairly profound statements. And why we're here today celebrating Jong-wook is due to at least half of the reason is in this picture here on the very far right, and that's Dr. Lynn Stansberry, who is Dr. John Hess's wife. In 1978, I believe that you met Lee Jong-wook, and when you were both working in Korea, John with the U.S. Army, and Jong-wook in an emergency room in a small hospital. They eventually all moved together and actually lived in the same home in Hawaii when both John and Jong-wook were studying and eventually got their masters in public health. And here's just a beautiful picture I thought I would sort of put just to show, because it looks like a pure unmitigated joy. And then this is a wonderful picture here to celebrate those who have endowed this lectureship here, Doctors John Hess and Lynn Stansberry. I asked John, how should I introduce this lecture, and he wrote, how did you know this guy? Because I didn't know Lee Jong-wook. And he said he was a close personal friend at a time that he could not leave in either Korea or Japan with his Japanese wife. Lynn and John gave the University of Hawaii School of Public Health the funding for a scholarship, and their family lived with them in Hawaii, up in the Manoa Valley behind the university for 2 years. They ate dinner as a family together and really considered themselves as a family. I'd also like to point out that that Drs. Hess and Stansberry have been very generous in the department too, not just this, but also, as you probably remember from one of our recent MLS graduations, the Roxanne Gary Endowed Fund to recognize MLS students who excel in transfusion medicine too. So I'd like to thank John and Lynn for endowing this opportunity here. The first and So what are we doing here? I talked with John about this, and what he said is he'd like to have this opportunity for this lectureship to recognize and celebrate contributions to the public health made through pathology and laboratory medicine and pathology. And for those of us who were, involved in the thick of it for the last few years, there was really no one more appropriate to acknowledge and to hear from in that exact sort of vein than Dr. Alex Greninger. I've put a picture of here of Alex Greninger, largely because I don't know what to say about someone that hasn't been already said in the national news media. So, Alex was here. This was, I think, an advertisement from perhaps Twitter or something for his view on Frontline. For those of you who watch HBO, this was also put onto the John Oliver show. Alex has been recognized many times in the last few years for his contributions, especially during this pandemic, and was in fact recognized with also Dr. Jerome in our department as the UW's Inventor of the Year for their timely bringing online of our LDT COVID test, which I think we all recognize was really transformational and incredibly important for our progress in the state of Washington during the pandemic. Alex is an assistant professor in the department and assistant director of the virology lab. He's highly accomplished, as I think many of you know. In March 2021, so I only have a year-old CV that I just pulled up, he had 157 citations with an H index of 53. So for those of you who are considering going up to full professor, just understand that. And he has about 55 accepted papers in the past year with 25 papers in process. Okay, so Alex is very productive. I think, as I said, this is the most appropriate way I think we could recognize the laboratory's contribution to the public health. And so with that, I would like to introduce Dr. Alex Greninger, who will tell us about the laboratory public.
Thanks a lot, Jeff. I really appreciate it. And thanks to everyone for being here for Laboratory Grand Rounds and our inaugural Lee John Wook lecture. So I didn't know what to call this, so I talked about the laboratory public to talk about, we'll talk about the public health aspects of our laboratory testing. From a disclosure standpoint, it's increased a lot in the last 2 years. We have a lot of partners we work with for central contract testing for clinical trials and for diagnostic manufacturers, as well as some research support. And then my wife works at LabCorp, so I'm hedged in case they ever buy UW Lab Medicine. So I wanted to start by just going back to 2003. Personally, for me, it was a time of, when I graduated from college around 2003, 2004, and just looking back, at this experience that affected my life a lot. I didn't realize it at the time. At the time, it was just when SARS really didn't come in the U.S. that much. It kind of came and then it went. I mean, by the time we had identified it in March of 2003, it was gone by June 15th, 2003. Testing wasn't a huge aspect of it, but personally, it affected one, what I did shortly thereafter college, and two, also from a science standpoint, I got really interested in viral detection because it took so long for the virus to be identified and then for tests to be available. We did it entirely based on sort of a non-viral discovery standpoint. And one of the ways it affected me was actually very, very locally here, and this is relevant for this particular lecture, is that I was sitting there in my last year of college, reading the front matter of these journals, the only part that you could actually understand and read from these journals. And there was this article, it's this short, this is basically the entirety of it. It was only barely 2 pages. And it was called Global Fire Brigade Response to Disease Outbreaks. And it was about the World Health Organization's global alert and response network efforts. And this is literally about what it was like at the time. They did this, their situation room there. And I had been working on a sort of an honors thesis at the time where I had to email with a few people at WHO. And so I had divined how to make an email for someone at the World Health Organization. You take their last name and you put their first initial at the end of it and you put at who.int and you can write anyone in the organization. And I thought that this was really cool that this thing existed. And they had these 2 guys here. So Mike Ryan kind of went viral during the SARS-CoV-2 pandemic, and then Klaus Stor was in charge of the influenza work at the time. And I just cold emailed them from undergrad and was like, hey, I want to come work with you guys. And in 6 hours they responded and were like, sure, come this summer. And so I ended up working in the summer of 2004 for this team, and I played, my role was mop-up guy for the SARS-CoV pandemic. So I went around the headquarters and I interviewed a bunch of scientists and people in the organization. What did you learn from going through this? And the thing was firmly done, but how can we make guidelines for responding to a pandemic? So one of those things you do in college was there for like 3 months, you put it on your resume and you say, I was an intern at WHO, but what you really did was diddly squat. But I had no idea that going forward, that like, something like that, you're like, oh, we're gonna replay this, almost 20 years later. And this was exactly the time that Lee Jong-wook was the Directorate General of WHO. I don't remember interacting with him at all. I was a stupid intern. But at the same time, it's interesting to think back about how, some of these random experiences from early in life go forward. And it's a hot topic again because at the end of for SARS-CoV-1, they had to redo the international health regulations. We thought we were going to do all these different things, that we're going to change this. And here, this is the Wall Street Journal actually from like 2 or 3 days ago, and it's Bill Gates basically arguing that we need a global alert and response network. And literally, he says he wants to fund this, but the exact same team that is funded for exactly this kind of work. But it runs into these efforts are always run into these very difficult international political issues. That's one of the things learned at WHO is how much it is an international organization and not a supranational organization. You're very limited in what you can do. Another thing that I learned from that particular effort, one of the things I took forward and I really like, and I wish I could integrate it in more things in my life and maybe make me a better manager, Mike's here, is the idea of terms of reference. And because it is an international organization, you have to be very clear about what you're allowed to do and what you're not allowed to do. And when you start your first day, you get a document, and it is your terms of reference, and it is exactly what you're supposed to do. This is an example of one for a committee, but they do it for the individual jobs there too. This is what you're supposed to do. And so it's really easy. You just take that document and you pen it above your desk, and like this is what is inbounds and out of bounds, and you can just look up and be like, okay, I can do that. I'm allowed to do that according to my job, not just a job description, but something that's very clear, the terms of reference. And I thought of that when I was getting ready for this particular lecture, because it's an inaugural lecture. So I really had no idea up until last week what we were doing here. And so I wrote Jeff, and I copied email as I want to do. Just put it on a. Just be careful what you write me, Jeff. I'll put it on a slide. So the point of this lectureship here is to talk about lab medicine with public health. So that is what I sort of organized this lecture around, so some of our work in the virology lab as it relates to public health, what we've done in the clinical lab for this last pandemic. I focused on SARS-CoV-2 because I thought it was probably the most relevant, and how we think that we've improved the health of the public. Though these things are very hard to measure and hard to know, So let's frame it as a little more than 2 years into the COVID pandemic. What have we done in the Department of Laboratory Medicine and Virology, and how did it help? So the first thing is we've certainly done a lot of clinical testing. I like this slide really makes it very clear. I like this dashboard. I did update it for today. So we're at 4.76 million tests performed. We detected 372,000 infections during that time. Our test positivity has crept up considerably in the last few months. And we are still going along, even though test volumes are lower, we're still going along at 6,000 tests a day. Still right now, and we're creeping up. Our positivity rate is very high and right now. And there are, just this slide, I could sit here and tell, sometimes I just stay on this slide the entire talk because you can just talk about like the very, very, the creeping up at the very beginning, not creeping up, the dramatic increase in the first 2.5 weeks, followed by the time we thought we were going to be maybe just done and we should just, shut it down in the next 2 months, followed then by the governor coming along and saying, we're going to test all the nursing homes. That was very memorable from the standpoint of they divided the state up into 3 groups and 3 areas, and we took 2, and another lab took another one, and they crumped after 2 days, and so all of a sudden we had the entire state that we had to do, and the samples arriving in these very difficult conditions, to then the opening of the drive-thrus and what a successful approach to our testing that has been all throughout the pandemic. And I have this slide as well. I like to thank, there's so many people in the department. Everyone in this room has contributed. I specifically called out, I bolded even some of our Together We Will winners. 2 of them were announced actually, I think today. Jennifer Greenwood and Aaron Goker, who's been involved in a lot of clinical trials testing, and Jennifer, who's helped set up all of the testing that we have collected since July 2021. So before, most of that testing was collected by employees of the city of Seattle, and now it's collected by the Department of Laboratory Medicine, something that we never really thought we would be getting into, but has been a considered effort, especially given the fact that, the July 2021 things look very different, even just like a month after you start the job or a month and a half after you start the job in terms of how much work it's going to be. We have people who helped set up the assays, helped set up the sequencing. Our lab ran for, we were typically a 7 a.m. to about 10 p.m. Time frame normally before the pandemic, and we've been 24/7 ever since the pandemic started, and that's now over 2 years. And so even the people who have just sort of cracked the nut of staffing at the University of Washington, being able to hire hundreds of people, has just been an incredive effort. You even have the basic scientists covering for other individuals, helping set up pipelines we can then transfer over to clinical. And then sort of more recently, the move to the lab in Renton. We've had to move a lab in the last few months now. So we're doing all the testing down in Renton now and handling that transition. So many people to thank for all these efforts. I thought that it would be helpful just to I always go back to these first 2 weeks, because that was by far the most memorable portion of I use this slide a lot, where it's basically on the bottom here is our testing from our dashboard for UW Virology at the bottom. So it goes from 0 to 1,500 tests a day, and almost after about just a little over 2 weeks, we were doing 3,000 tests a day before we crumped and hit our analytical capacity. And on the top is the COVID tracking project, which makes some estimation of the number of tests that were being done per day in the United States. I think this is outside the public health lab system. But you can see that these have been matched for the dates, basically. It goes from March 1st to March 14th. This goes from March 2nd to March 14th in the bottom. And all the point is that basically just the y-axis is pretty similar to each other in terms of the proportion of testing that was being done at the university, of the nation's testing that was being done at the University of Washington. And just never having thought about a test that grows, and Jeff pointed this out early in the pandemic, that grows basically exponentially. I'll never forget some of the calls that we got. The first day we went live, I remember so many things, the way we were set up, like the label printers that you would get that would print the labels as an indicator. We had a label printer above that was like 5 feet off the ground. We had 3 receiving desks in the lab. And the label printer would come out with an order whenever there was an order. And that's how normally you'd tear off, and there'd only be they would come in as they come in, and that's all right. But for this particular test, I remember the label printer, basically the physicality of it just going to the ground and looping back around on itself, and then coming farther along the ground as these orders basically just came in almost like a ticker tape. And I speak to that to the point of when you're in the laboratory, really having no idea what's going on out there. At some level, we were so focused on, just making sure the test works, getting people staffed, figuring out how we were going to do this, how we're going to make this happen, and having in a way, almost a privilege of not being in the hospital and dealing with that sort of fear. I mean, I think there's some quotes: "The safest place to be during a pandemic is in the laboratory." People offered that quote before, and just sort of it's a cognitively almost sort of safe place. At the same time, we were worried about outbreaks in the laboratory, but just this incredibly vivid. I remember some of the phone calls too from the clinicians. Basically, when we actually took the test off for a few hours because we had to make sure that everything was working just perfectly at the very beginning, and basically clinicians calling saying, "You've got to bring things back right now. We have no idea. The ER is completely full. The hospitals, people are they're having triage. They have no idea what's going on," and they wanted something to be able to offer that. And I still see it now when you interact with the infectious disease team or other clinicians. It's just for quotidian stuff, like a hepatitis C call or something like that, and they will really take the extra time to just be like, "Thank you so much for what happened here." And I still don't have an emotional way to have the sort of to really understand that. I don't, having not been that, but just been on this one side of this, that growth. But this is what I'll always remember, and I'm just very glad that we were able to make an impact during that time. I thought I'd make it a little bit academic from this particular time period, because there is actually a literature. Of course, there's a literature on everything for COVID. I once had to give a talk on CNS manifestations of COVID, and you went and there were 5,000 papers or something that had been published in the prior 36 months on this topic, and there's no way to synchronize or synthesize this particular knowledge. But you can look, especially in Europe, where they had national testing schemes. So here's an article from France where they're looking at, what does testing do? Now, obviously, there's not like a randomized control trial of like, we're going to test these people and not these people from the beginning of the pandemic. For everyone, it was just like, we just know this. And this other thing I like about being able to practice in laboratory medicine is like, there's a lot of things, we're talking about clinical studies at the end. There's a lot of things that need to be studied. There's also some things that just don't need to be studied and just need to be executed. And I feel like we're often in that perspective in this particular one. I mean, I'd love to know, but so much of COVID has been pulling us out sometimes of that academic perspective and just about execution and operations. And so here you can look at this is a slide of, on the left they have the mortality, the deaths actually per 100,000 population in red, and then the number of tests they were doing per 100,000 population in blue. And amazingly, the only difference in the y-axis is about a 20-fold, which is pretty scary in many of these situations of what was going on early in the pandemic. And they did, just an observational look-see at, this period between around March 17th, 18th, when they started testing, to around almost from the end of the lockdown. So this is about May 2nd, the first week of May. So less than only 6 weeks of testing, and their estimation they broke it apart France by regions of who was testing when and how much, and adjusted it for a variety of things. They adjusted for socioeconomic variables such as the structure of the age, socioeconomic status, gender in the population, health facilities, medical density, and then time-varying confounding factors in different models, ICU occupancy rate, as well as they looked at neighboring states or neighboring sort of departments as well. And their basic estimation was that for every 1 percentage point in the test rate was associated with a decrease of 0.0015 percentage point in the death rate. So you could actually see sort of, obviously there's an observational trial. You could talk about all the different confounders and things that go into this and unmeasured covariates that, break apart areas that are able to stand up testing and what that might say about things about the population. But showing basically testing associated with a decreased case fatality rate. In this bottom, they didn't have a great figure I could steal from the Italian studies, but there were 2 different Italian studies looking at the same sort of thing, found a mortality rate ratio for every unit increase in the testing per 1,000 inhabitants of 0.92. There have been some others. This is on a large scale for that initial period of showing that testing makes a difference in something as brute force as case fatality ratios. There's another few studies, so a small one example of Slovakia in testing. This was again for the antigen test, but nonetheless the ability of testing to, and other things of course, no one just ever does, I'm just going to do testing in this pilot area. They had other enhanced control measures, but looking at the effect of testing. And so on the top you can see in yellow some of the control measures. So they had invoked things that they decreased gatherings of greater than 50 people and cut off wedding receptions and broken that down 2 weeks later to greater than 6 people. And then they went into a lockdown October 24th, and their extended measures. There's a lot of covariates here. But at the same time, they did do pilots where they took 4 countries with countries with the highest incidence in Slovakia and did a bunch of antigen testing then, came back a week later and rolled that out to every single county across the country of Slovakia, and then did it again in November 7th. And that's, unfortunately, the graph at the bottom is not super helpful because they actually they're not showing the cases. It's not like that was that dramatic of an impact. They actually thought that they were biasing by doing all this testing to look at the additional tests. But if they look at the effect and the reduction in prevalence, this is looking at infection now, we're away from case fatality, you can see a 60% decrease in infection prevalence after 1 round of testing, and then an 80% decrease after they did those 2 rounds of testing. So pretty, relative, there's obviously some variable across in sort of panel A there in the middle, but you can see there's a pretty big effect there of both these control measures, but of course also the testing is what they're really focusing on here. And even when they had that pilot versus round 1, they even had about a 50 to 60% effect, and you can see down in the bottom right, you can see sort of the colorimetric view of this, of the decreasing test positivity as they tested as well. Now, of course, that's not the entire study. I mean, this is basically published in Science and but, and it was held up as like why we should be able to do daily antigen testing, but no one could actually maintain this level of testing. So I sort of pulled from the data from Our World and data for Slovakia. This is the number of cases that have happened. And if you run it forward from the time they were doing the mass testing, so there where they were doing the mass testing, there we go. We have this. So they're doing their mass testing right here, and that's where they sort of are very proud of themselves for decreasing the number of cases viewed through what we know now of the entire pandemic, what happened later, what they couldn't maintain, what happened with Omicron. There's obviously a lot going on here. I think that's also been a very difficult portion of the pandemic is just, you do what you can, but at the same time, it's very hard to, the factors, the things that are going on are so large. It doesn't, you can publish papers, you could do clinical trials, you can offer testing, you can get up here and give talks, it's not, the things that are going on are so much larger than what we're doing just in clinical pathology. But it is viewed a different way when you look at the different testing from here versus the entire pandemic going forward, if you knew now. Here's a paper that looks at COVID-19 mortality, so back to the initial for case fatality, with looking at countries on a country level. So across the world, if we break up countries into, they do a whole bunch of different sort of segmentations here of high-income countries, middle-income countries, low-income countries, different government effectiveness scores, percent of their population that's elderly, as well as the number of beds that are in the ICU beds. And you can say overall, adjusted for case number, critical case rate, various country-related factors, one additional test per 100 people was associated with an 8% reduction in mortality rate. Very similar actually to that Italian study that was showed early on. But you can see this on an ecological basis between countries. This is, again, for the very first few weeks of the pandemic. Where, just even, obviously there's some effects here for different beds and whatnot, but testing is, again, we don't have measurements like this for Washington State. I always felt like in the first year and a half to year and a half, the pandemic, Washington State did quite well, and I think we really honestly congratulated ourselves for being helpful for early in the pandemic as well as throughout. Certainly Delta, we had a much longer sort of Delta wave, and then Omicron really, roughed up everyone. But it is sort of, I don't want to say we fought the virus to a draw by any means, but we've gotten to a point where we're in a more sustainable state. And then certainly for China, I just thought to put in a study here. This is a nice descriptive paper, I think it was in Nature Medicine, on all the various amazing things that have happened in China from a testing angle. What you just saw with Shanghai. Or Beijing, but this is just, I just want to put this up here just to sort of cover, some of these boxes are kind of amazing where it's like, all right, we're going to screen 10 million people over the period of 2 weeks, and then we're going to come back and during the same time, or just a month later, screen 12 million people, 2.3 million people, 4.5 million people, 11 million, just millions upon millions of tests, kind of puts our 4.76 to shame from just a sheer scale of testing. Most of this was done basically on highly pooled testing, which we moved to early in the pandemic. We were actually one of the first groups in the United States to be able to perform testing, thanks to our friends in Washington State from a regulatory angle. But I know a lot of individuals don't trust all the data coming out of China, but at the same time, you have to say that their caseloads have been quite low. If based on this particular data, and testing, I think, has played a huge role in that as well. That's been a major portion of their response throughout the pandemic. So I felt like it was worth sort of giving a shout out to the amount of testing there to be used in control. I think another way to think about what we've done here in the department from a public health angle is, and I'd say this sort of, during the pandemic, we were very focused, as the pandemic continues on, we're still very focused on operations, and there's sometimes we do the numbers and be doing a test like every 7.5 seconds. You had no way to actually relate to what was going on out there. And so at the beginning, but even throughout, even when it was about people getting tested to travel to Hawaii or something like that, you only heard about the edge cases, the times when the test result came back late and they couldn't get, or someone would call and say, I've got to get on, I've got to get this test by this time to be able to do this thing. Those are the only time that individual stories, and as we sort of opened up now, I think I've heard more and more stories about, what that testing has personally meant on a household level, on an individual level. People, when I took the picture, I included our turnaround times, which is something that, to Jeff and Patrick's credit, we've really focused on throughout the pandemic, being able to offer very quick, high quality testing throughout the pandemic with a very rapid turnaround time. And I think we've been very fortunate. I think some of the times during the pandemic we've been asked to talk to other groups, and it's hard. I love this model. This model works very well so that you can go get a PCR quality test and get a result basically in the same day. And even just a few counties off of our county, if you have to go to a CVS or you have to go somewhere else, you're talking about a 3 to 4 day wait before you get something back. And you talk to other places around the country, it's just not something that can be offered. To have not really a compromise between quality or less of a compromise between quality and turnaround time. And I'd also personally throw out my own, story here for the public health. The testing here is personal. I just tested positive 2 weeks ago. It was a case where antigen testing was negative ×2 for a day and a half. I went and got a test, got a result. I went at 8 a.m., so I didn't get a test result till 6 p.m. So I was, texting Patrick about that, saying, I gotta run more couriers, But still, it came back positive. Certainly, I thought implicitly, this has got to be COVID. But your CT is 31.4. You're early in symptoms. It's something that you can get on PCR, but not on antigen. And so, even as we think that we've solved certain things about COVID testing, even 2 years into this, having this framework and being able to get this result. And I think that I probably passed it on to 4 people that I know of in the 8 totally pre-symptomatic time period. I don't know how many people this test protected. I stayed home while waiting for that result. I stayed home the next week and a half. I don't know what the counterfactual is in all of this for this pandemic, but it certainly personally affected me in a way. And I know many, many people have those stories, and I sort of always appreciate hearing those and being able to participate in individual healthcare. I think, I got to give a talk to the medical virology course for undergrads, and it's, you always get this question, do you see patients? And you're like, well, no, but we do this. We've tested basically the entire Puget Sound area. We've seen the entire area, but I just saw 9 patients during residency. And so how do you balance, this is an incredible ability, and that when you go into this field, but to actually experience it through your sort of, young faculty, sort of young directorship time is been an incredible privilege and something I hope we don't ever have to do again, but it's part and parcel. This is just at a slightly different scale, but it's what laboratory medicine is, nonetheless, throughout the entire principles of it, everything that we taught during residency. This is just the same. It's high quality testing, it's operations, it's getting the feedback, it's how you're going to result it, how you're going to receive the order, how are you going to ensure the specimen stability, how are you going to get the result out, and then you let that out into the world. You don't actually know if people are going to use the result. That's, it's a little bit separate from us to some degree, but you try to make sure that they're using it in the best way, and you offer the highest quality testing and the fastest turnaround time at a great price. And so, this has affected me locally. So that's all I wanted to say about qPCR from a clinical testing angle on the side of how our testing has affected public health, both on the macro and sort of on the micro. It wouldn't be a talk if I didn't do, if I wouldn't want to talk if I wanted to talk about sequencing. So I wanted to talk a little bit about sequencing and what this pandemic has meant, from that standpoint and for our department sort of going forward. So we've had a lot of growth in this space and sort of instrumentation and work. We went into this pandemic basically with just this little, MiSeq. Where did they go? Just our little MiSeq there. We went the entire pandemic. Illumina Siptus, a NextSeq 500, which we had for the first year, and then we upgraded that to 2 NextSeq 2000s and a NovaSeq. A lot of instrumentation from different groups now, with a lot more automation and a lot more scale. And we actually got a CDC contract. We've been working on different clinical trials, and we just got re-upped for the CDC contract for another 3 years. That's really, it's on an annual basis, but that's, we'll be able to maintain this. I think that's what's been amazing to see throughout this. Just to give a perspective from a sequencing standpoint, this is my sort of, first love is viral genomics, but to see this actually play out. I'd come to you during residency and be like, let's talk about 100 HSV genomes or something like that, and what we did, and to know that there was this mismatch between what you could do technologically and what you could offer to people versus what was being done. And I think SARS-CoV-2 has really illustrated that, as this graph shows, just from a sheer number standpoint of genomes and GenBank or GenSaid. It should be GenSaid or GenBank, but we're up over 10.6 million sequences worldwide now. While before that, I mean, not saying sequencing is a good predictor of anything. It's a really bad predictor. Like, having lots of sequences is a bad thing, and it continues to be a bad thing. You look at your top hits there are SARS-CoV-2, influenza, and HIV, viruses we have not solved by any means. But when you look at the sheer numbers for the other viruses of what was being done and been known, I mean, you can't even. I mean, all they can do is basically put the font. They don't even merit like a pixel, on the actual graph in terms of what's out there. I mean, the maturity of this space of what we can do for public health, and working right now on grants with CDC and Washington State Public Health to try to build this infrastructure going forward. And we have a lot to do. I mean, I'm putting these numbers up here, but just from the utility and use of this information, the execution, how public health acts on that, there's still a lot to be done here. But certainly this is, I used to have a slide when I talked, like, if you build it, they will come. And now this is the opportunity to actually build the infrastructure and to build the response and execution and executive aspects of this as well. Locally, what we've been able to do is, from a surveillance standpoint, is basically sequence at a high throughput for about, for surveillance, about 46,000. I think including the clinical trials, we're probably about 65,000 in that area. And I want to give a huge shout out to Pavitra Roy-Chaudhuri, who's basically been managing this since day one. As we were totally pulled into qPCR and bringing up clinical testing, she's taken this and just run with it. And I think, we're really helping, push this revolution forward. Early on in March, I think we were doing something like 20% of the world's sequences in this space. We've been able. I think what's really amazing to watch is, obviously we know that, the virus is basically this has been a major contributor to what we're seeing right now, whether people have been infected, the speed of infections, the viral genotype is a key covariate. But you have to measure it in order to be able to do anything with it academically or therapeutically, if we can get to that space. And this is something that I just, one of the things that's been very impressive to me is to watch this get baked in to the entire response. If we're looking at vaccine efficacy, we're looking at monoclonal choice, we're looking at understanding how the virus is spreading within the hospital or in other areas, that we have this information available. Sometimes it's not super important. Sometimes it's not the most important thing in the world, but it is nice to be able to say, hey, this is something that's making a difference. We're also able to plug this into our basic science pipelines throughout the university. So we're able to help investigators get isolates for various different variants, test on different antivirals, test for the vaccines that are being designed here, and we were able to sort of get that, nucleate that virtuous cycle here for UW, and as well as for many investigators, including for the CDC, where sometimes we're the first groups to be able to genotype and find that sample and get that out to public health or for pharma. I mean, certainly, as I said, this is dramatically enabled the public health science of what I call an emerged path. It's just no longer emerging, it's emerged. But, it's incredible. These are things we've never gotten a chance to really, do on a high scale, but look at the increase in fitness over time. I mean, this is the virus that kicked my butt this last few weeks, and it's incredible to see how transmissible and to be able to measure this in real time on a sequence basis for all these different variants, as well as new hypotheses. So I saw this from Larry Corey's perspective in New England Journal on, we have this sort of molecular clock that goes along for all the variants, but these phase shifts that are each of these specific variants and how they're off the line, and hypotheses around this being emerged in immunocompromised hosts, potentially animal hosts, but really probably immunocompromised hosts. And so, this is an area where we can bring a little bit more effort from a public health angle of understanding what's going on. We're not there by any means. We don't have a crystal ball. We're totally reactive, and we're really just fortunate that Omicron just does not like to progress to lower respiratory tract disease, and our vaccines still work quite well. But these are new hypotheses that before there was a small world of looking at these longitudinal infections in immunocompromised populations, if only because it's the only place you could actually go to look at where the virus evolved through time, because they had the virus for 100 days or 200 days or 300 days. But I don't think there's very few people who put it forward, who try to connect the dots that said, okay, that's interesting evolutionarily, but it might actually emerge out of that individual and come. It's like a training ground for the rest of the population. And this is something that we've, having that sequencing throughput, having better coverage, being able to do this is going to be something we're looking forward to even more in the future. I wanted to highlight a couple of papers from our own group here. That this one is sort of near and dear to our hearts. It's variants of concern are overrepresented among post-vaccination breakthrough infections of SARS-CoV-2 in Washington State. This is just looking at back when we were still having a honeymoon with the vaccines, and we thought 95% it's going to stop infections, in early 2021. And with this paper, I think we finished in April and put it online in May. And it's a very simple abstract, so we had 20 vaccine breakthrough cases among employees here at UW-MC. All 20 of them were due to variants of concern. They were mostly epsilon. They were not the most, variants of concern from a transmissibility standpoint, but from an immune escape standpoint. But it was 100%. I mean, it was enough to be significant relative to everything else that was not a vaccine breakthrough case. And this is the first one of the early shot across the bows of sort of vaccine breakthrough cases, as well as I underline here this sentence, which to me really was very interesting and illustrative at the time, that the CT of these vaccine breakthrough cases was 20. I mean, that's on the order of tens of millions of copies per mil. I mean, these are very transmissible amounts of virus, unless you assume we're not doing culture here and we're not looking at other aspects of infectivity. But assuming they're not all completely bound up by antibody, the people were, symptomatic, and they were, putting out tens of millions of copies. It's not too unreasonable to suggest that these are going to be transmissible with this kind of virus present. And sure enough, it wasn't until the Provincetown outbreak that the CDC basically, this is the time when the CDC was basically, the week they did this, they said we can take the masks off, right? And at the time we put this out there, and you're like, this is not you'd like to think these papers are connected to some sort of, it was the opposite at that particular time. This is the zeitgeist from the other time. And it took until the Provincetown outbreak. Of course, when the Broad does it, it must be true. And so, that basically everyone's like, oh, wow, vaccine breakthrough cases are transmissible. They at least had evidence of human-to-human transmission. So I'm not, totally slagging, but just we had this data out there, and we were part of this early to say that this was true and this was going to be a problem going forward. From a laboratory standpoint, I think having the sequencing in the lab has been very helpful to understand the genotypic basis of diagnostic failures. This is one of my favorite things from laboratory medicine. I really like this story from a laboratory medicine perspective. But basically, when the antigen tests came out, we would get the antigen tests sent to the lab to evaluate, to be like, okay, how well do they work? What sensitivity? You take a sample, you dilute it down, you test the initial LOD, the confirmatory LOD, you go to your bag of samples, you take 100 samples of varying CTs, you test them against this antigen test, and what do we all know? It needs to hit 95% sensitivity in order to be good. That's good enough. And 95% is not 100%, so you're allowed to miss a few. And sure enough, we had this test, the Quidel-Sofia antigen test, that had a 95% at 50,000 copies per mil. But the crazy thing about it is that there's one sample that it missed that was at I forget what it was at. It was CT25. It was in 1 million copies. It's just no reason it should miss this, everything being equal from the amount of virus that's present there. And so, what we did is basically take that sample and I didn't want to put a paper out that was just here's 95%, this is the analytical sensitivity. And so we took the sample and we sequenced it. Said, hey, let's just pull that thread. Very easy to do. You get the data back in just a couple of days, and you have this mutation present that is, or two mutations. Now the antigen tests are focused on the nucleocapsid genes, not on spikes, or a little less, people know these ones fewer. There were two mutations relative to the reference, and we were able to go back because we've done so much sequencing. We have a whole bunch of positives have been sequenced. We go back and we pull a whole bunch of samples. We don't have any samples that have just this one mutation, the D399N, but we have a bunch of samples that have the both mutations, as well as a bunch of samples that have the T205I. We can go back and we can test it against the Abbott kit and the Quidel kit, and we see that the Quidel kit basically whiffs on every single one that has these two mutations, and the Binax now is your positive control, and they both detect the one that has a single one. So really implicating this particular mutation. We went out and cloned it out and put it in the basic science laboratory and showed that it was this particular mutation. It affected the analytical sensitivity by 1,000-fold. called the company, let them know. All of a sudden, they get their antigen mapping data, and that site is bang on where their antibody. And this is something we don't talk about. You know, the molecular tests have been very good throughout the pandemic because we've been insured against viral evolution by having 2 targets present on every test. So even if there's one mutation that knocks out one of the targets, you're not going to get 2 targets knocked out. It's very uncommon. But antigen tests have always had potentially this happen, and we're just lucky that where they chose to put their antibodies, many of them don't have epitopes maps. They don't even know where some of their antibodies bind in these antigen tests. And this is the first example of a variant that affected antigen test performance. Now, luckily, this did not take off. It didn't happen to like hitch a ride with one of the spike variants. And now, because of this work, we ended up, working with Elizabeth Quidel. We worked with RADx, the NIH program, for finding. There's a whole committee that looks at these tests and how they're. So we provided a lot of samples from our genotyped banks to evaluate. There's a group at Emory would take antigen tests and PCR tests and actually, test different variants. And they would, go through GISAID and be like, we want that one and that one and that one, and send them in the mail like that week, and be able to see how we're going to handle when new variants arose. But this was kind of an interesting story. There's, the whole project from start to finish took like about a month. That's the other thing that was cool, just from a process standpoint. You get that, one person can do 100 of these things in a day. You get that one, you're like, we should sequence it. Let's just sequence it. All right, sequence it, get that, go into the data, pull these guys, test it, and then go clone it out and test it and prove it. Boom, 1,000-fold, and you're done. And that's all it takes. And so we can have these sort of edge cases. You can take diagnostic edge cases and be able to pull those threads and understand what's going on in your laboratory and let the world know. It didn't turn out to be something of great public health import, but you don't know that going forward. Recently, yesterday we had a paper go online. This is a little bit, now it's like the virus moves so freaking fast that you can't keep up with things. So now this is a little bit of like, people know about this, but in January, we were doing some testing with the RADx program as well, looking at genotyping Omicron and Deltas with the qPCR test, the qPCR genotyping test to look at whether we were seeing Omicrons or Deltas, to look at the change in the percentage. And now we look at BA1s and BA2s. So basically, they're all of therapeutic import. And while we were doing this, we had these a few of these like edge cases. So this is a qPCR plot where you're seeing, okay, here's your Omicrons and here's your Deltas, your genotyping specific locus, and these are the specific locus. But there's a couple of dots here that show that basically both alleles are present. And there was another lab, Helix, that was doing the exact same thing. And we chose a couple examples. They ended up having like 20 of these over the time period we're looking at in January, or in December and January, when both of these guys were spreading. But it's indicative of Omicron and Delta being present in the same patient. And so we can go forward and look at this in ddPCR and show, hey, we've got 2 populations. We've got populations and populations and populations. Basically, there are 2 different viruses here. We're looking at the 452 and the 501. We're seeing 2 different populations of viruses present at the same time. Sure enough, you go through and sequence these guys, and you've got the allele frequencies are mixed. They're not clonal throughout all these mutations that decipher between Omicron and Delta. And Helix even took this one, so we're able to show that we're getting Omicron and Delta in the same patient. And the reason I say this is sort of old news is that by the time we basically finished this work and submitted the paper, people were sequencing recombinants of Omicron and Delta, and now it's been known in France and in the US. And actually, Helix took it farther and found some of those examples. They even found some of these examples where the samples were in the same patient, and you could literally see the recombination happening in the patient. And this is another thing we've always known about coronavirus. They love to recombine. You just got to have so much virus that they end up in the same patient or the same individual that you can see that recombination. And it's one of the things that I'm probably the most concerned about going forward is like, we don't really have a good understanding on a genotypic basis. We know where our therapies work and whatnot, but we don't have a good understanding of, all the drivers of, why was Delta have so much of a worse sort of mortality and morbidity compared to Omicron. We think a lot of that has to do with spike, but there's an opportunity for it to sort of mix and match. Like right now, we've kind of walked ourselves into this area where everyone's vaccinated against 2020 SARS-CoV-2, and we've got Omicron, which has more than 30 mutations to it, so we're not as well protected. We're protected at least from the hospitalization angle. But there's an opportunity here for some, more crazy recombination to happen during this time that would bring the sort of immune escape of an Omicron with something that had the right sort of non-structural gene mutation or something like that of Delta, or an accessory gene. So there's still, I mean, we're not by any means, I feel like there's this sort of, we're here talking on my mask on, I'm talking to you, we're all here in the same area. I mean, we sort of like, we fought this thing to a draw and we're moving forward. And there's still that risk, we're not out of by any means, and there's still some percent chance of a severe downside there as well from a recombination evolutionary angle. I would be remiss if I didn't talk about work that has been going on in both our labs at 1616 and at Harborview. And I thought about, when I originally thought about this talk, I was like, hey, one of the things that could really pivot here is like, well, we don't have great understanding of how our testing, and we think our testing has impacted the public health, the health of the public here in Washington State and the region. And we really think that, but we don't have perfect proof of it. But we certainly know that this testing, from the standpoint of these clinical trials that have been done at UW, has had a measurable impact on the health of the public. And these are all of the viral loads and sequencing and serologies we've done, mostly at Harborview. But there are some big heavy hitters on here on this list. We've got the entire NIH therapeutic pipeline went through the ACTIVE trial. So Bob Coombs helped lead this through the ACTG for different therapeutic trials for antibodies, a big adaptive trial. They've looked at 6 or 7 different agents so far. We did the phase 3 viral loads for Janssen, Novavax, and Sanofi. We were actually the confirmatory qualitative test for Novavax, so we decided who was a case and who wasn't a case for Novavax, which is the endpoint of that trial, as well as the serologies for Novavax, which determined who was eligible to be an endpoint in that particular vaccine trial. We did the remdesivir testing, so the original trial. It was also run here at UW and around the NIH trial. Now, initially, it was just, did you leave the hospital or not? But they collected a lot of specimens that we went and showed basically that remdesivir had reduced viral loads in people who had gotten tested early enough. And I think I'm just most proud probably of this recently, the Pfizer Paxlovid trial. So we did the viral load testings for this to show that basically decreased viral loads that helped lead to its authorization as the best drug. But remdesivir and Paxlovid, remdesivir was not given very early in this trial, but when given early, it's at like an 88% reduction in hospitalization, and Paxlovid is an 89%. They're the 2 best drugs against COVID that can be given in sort of one of the most easy areas. So there's a lot to be said about this work that has impacted public health and will continue to impact the public health going forward. We did some work on actually a Gates-funded trial on hydroxychloroquine for post-exposure prophylaxis, showing that it didn't do much or spot. And we've also worked with a lot of different diagnostic manufacturers to help get this revolution in antigen testing throughout. So I sort of went with these already, but here's the trial for Paxlovid, basically showing that 89% decrease in hospitalization, as well as, and this is the key part we played in for, was the difference in viral loads. So present in seronegative individuals, seropositive. If you had more virus present, you had a bigger difference. But it was basically about a log difference they're able to see. And the immune system's so good at clearing the virus in many of these individuals that it's actually hard to show a huge viral load difference. You can see as the sort of blue line goes down in both of those areas. The red line is the treatment area. So you get big effects in hospitalization for this trial, but not as big as effects in viral load. But still definitely measurable and significant. And the FDA looks for that biomarker testing. It's part of the package that gets submitted with the hospitalization data. The sequencing comes hot on the heels of that, and we're just finishing up that right now. Based on this sort of data, we have the Test to Treat initiative, which we know from antigen testing takes a little bit of time to get consolidated and offered to the population. So we're not actually on our front foot for Test to Treat. And unfortunately, it just failed its post-exposure prophylaxis trial, which is unfortunate. And then for Novavax, hopefully, this is actually a very interesting trial because we really had to work very hard to get the testing done. It came hot on the heels of the Janssen trial. They enrolled like banshees. These trials were enrolled so fast. One of the most exciting things about one of the silver linings to COVID is the energy with which what was brought to the clinical trials is something we hopefully don't have to give back in other areas. Our trials will move much faster. There's much more interest. The pipelines and the energy to it. To enroll 30,000 people in 4 and 5 weeks, it's just not typical of what was a trial back in the day. But here you can see basically that sort of 90% reduction in infection. This was both in US, Mexico. They also did a trial in the UK and South Africa that had similar numbers. And then what's also been very interesting in these particular trials is the sequencing data is submitted at the exact same time. The FDA wants to have every positive sequence. They want to know how the vaccine is doing, and they're not going to authorize your vaccine until they have that data. So typically these sieve analyses for vaccines would be done over years, after the trial's done, but now it's like basically done on a week-by-week basis as the cases come in. So I've got about 5 or 6 minutes here that I want to talk a little bit about what next for the laboratory as we sort of go down to Renton and continue to grow in these spaces. And so this is sort of where we're sort of thinking, what we've been doing. So obviously there's been a huge sea change in clinical virology and clinical testing. You go to these conferences for a long time, they talk about point of care testing and sequencing and point of care testing and metagenomics and point of care testing, and it was this huge cognitive dissonance between the two of them about what was actually going to be the future. Well, it's clear that point of care and at home has clearly won out. I mean, that's something that is actually happening in people's homes. The sequencing has not necessarily had the as impact on a therapeutic basis. So there are now over 400 tests that have EUAs. And those are going to have to be transitioned to 510Ks and other clearance from the FDA. And we know, especially if you want to be at home, then you've got to have that. And so that's something we're working with a lot of different manufacturers now on helping them transition through that portion of going from an EUA to the 510K. And we've worked with a lot of different manufacturers. They've got to use us as sort of the usual testing in the central lab. And so they run big trials where they collect antigen tests, send in a swab to us. We run it on whatever platform they want and help them understand what their sensitivity and specificity is and help them get through that authorization. That's been a big contributor that we can offer our sort of, central lab, usual care testing with this sort of ongoing diagnostic revolution as so many people try to get in the home or in the pharmacy or CLIA waived or, this, that, or the other. I've showed this slide before, and I wanted to say I still think that managing this revolution in sequencing from what we can do on the left for SARS-CoV-2 with the gap we have for these other viruses is something that we've always had a major import. This is something we've been working on a long time in other viruses where we've contributed to. The numbers are much smaller there, but we're always trying to contribute to epidemiology, therapeutic, basic science, the whole thing for basically offering genotyped isolates for different groups where some of these viruses were significantly portioned. Going into the pandemic, we were the leading sequencer of human seasonal coronaviruses at 57 or 58 samples. It was, incredible, but nonetheless, it was, there's just no interest in these things, and to be able to offer that. And so it was actually very edifying to see, that data get used during the pandemic to make forecasts about what was going to happen with SARS-CoV-2, because you could actually go back, and if you're trying to run SARS-CoV-2 forward, it's helpful to look at 20 or 30 years of other seasonal coronavirus evolution. We still have to keep pace with all the antiviral and vaccine trials. Here I'm showing one graph from one of our active trials. This is looking at monoclonals for SARS-CoV-2. And so here we're able to show in this trial of bambolizumab that basically you can see individuals for which you're able to see a reduction in viral load. It gets an E484K mutation. It sweeps in a day. This is daily swabs. These are incredible stuff you can do on a clinical trial. And you get a recrudescence, you get that increase in the viral load back up, and then finally your immune system comes on and clears it. But basically to show that day-by-day evolution of the virus and how it affects resistance to BAM and to other drugs, this is something that we did all the viral loads for this. Harvard did the sequencing for this particular trial, but we got to keep pace of all these antiviral and vaccine trials, both the scientific agenda as well as the regulatory agenda. We recently are going to get an NIH grant for broadly active antivirals. So we're going to be a genomics core for antivirals that could work against any virus of pandemic potential. So they want basically to have an antiviral that's ready, that we know works against existing members of a given family. And so there's been a lot of money put into this, and we're going to be a genomics core of a center that's run out of Georgia State and Emory. And I highlight here this paper in 2019. I don't know if I talked about this before with you guys, but we were actually working on what was called NHC at the time, but is now named molnupiravir. We were working with it on 2009 H1N1 virus, showing that it was basically a catastrophic air catastrophe inhibitor. So if you don't put it in there, you get no mutation across the genome. You get a little more at 1 micromolar. And then when you hit a critical threshold, you start to see this low-level sort of grass of mutations that are randomly scattered throughout the genome that lead to these sort of transition mutations as you get this dose-dependent effect. It's basically a sort of a air catastrophe inhibitor that works against a lot of different RNA viruses. And this famously went forward and is now authorized for SARS-CoV-2. But drugs like this, it's not the best drug, but it's a good drug that we'd like to be able to have for other viruses. And then finally, I'm actually on a plane after this going to DC and then to Kenya, where we're helping to build laboratory capacity. What we can do here for discovering and detecting new viruses through this USAID Deep Vision project, which is both from a scientific angle to find new coronaviruses, paramyxoviruses, and filoviruses in a whole bunch of wildlife and animal specimens with some limited characterization of that work, but a lot of it's genome recovery and getting that into databases. And we're building that capacity between countries around the world. So we have to go choose labs that are going to be involved in this and going forward for discovering these viruses, but also helping build up that metagenomic ability. You know, what you think about what China was able to do when they actually said, hey, there's something going on. That genome got sequenced. Thankfully, it went online. 24 to 48 hours later, we have vaccines designed. We have diagnostics that can be manufactured. And so reducing that time is very important, and hopefully coupling it to an executive function that's able to limit that spread is of incredible importance. And so I say this is only really possible with the resources that we have here at the University of Washington in our Department of Laboratory Medicine and Pathology. I think we really are able to realize science in the clinical lab to improve the health of the public. And I think this ability has always been there, and we always do it. We've just been amplified with the COVID pandemic. And with that, I'd love to thank really everyone in the lab, Keith, Pavi, Greg, Bob, Jeff, and Patrick have played a huge role, Aaron, Glenda, and Emily in the retrovirology lab, all of our scientists. This is when they came. This is come to work dressed like Alex Day, where everyone wore New Balances and a hoodie or whatever, as well as the basic science lab that's contributed to a lot of this work as well. And with that, thank you so much for listening. And happy to take questions upstairs, probably.
Questions, and then I'd like to bring to your attention, there's a reception up there, right up there after this directly. So are there any questions we might have? Nick?
What do you think about wastewater monitoring?
So wastewater monitoring is a tough one. It's one of those things. It's a clinical laboratory, and the question is, what do you think about wastewater monitoring? I mean, it's one of those things. It's like relative to nothing, pro. Relative to sampling more people and individual testing that influences the health of individuals, and coupling that to data that allows you to get that data and use it from what's going on in the community. We're seeing that right now, right? We're only testing ourselves 5,000 to 6,000 samples a day. I think we're definitely in the middle of a peak right now. I mean, at 18% test positivity. We're missing stuff. So if people aren't going to get tested at home with antigen testing, aren't going to ship the data, we've got to have some aggregate information there, and that's helpful. But let's also understand its limitations, that it's not influencing your therapeutic detection as much. You're getting aggregate data, and that is in self limited. And it's, I think from a clinical standpoint, I think I'd like to see us do both. I think that obviously infectious diseases COVID has been amazing in terms of the resources mobilized to it, but normally we don't mobilize enough resources because how much your testing impacts individuals. Like wastewater testing is not going to stop you from giving the virus to another person unless it's coupled to a successful policy response. So, pro relative to nothing, like to use the data, maybe helpful for finding what variants are out there, but you don't know if it's, some of these wastewater schemes are combined gray water, right? You don't know if it's like, a deer or a person in some communities. Like, right, there's a lot that's missing there, so.
Mark,
great talk. Thank you very much. What is known about antiviral resistance and the sequencing data that you have? Can we predict future resistance to antivirals, or can we?
So the question is, can we predict future antiviral resistance from the sequencing data? And this is an area that's very hot and very interesting. We're doing better than we ever have in the history of time. That said, that's a lot of infections and we have a combination and you have all the different mutations. We're good. This is work that's being done here at Fred Hutch and UW, in terms of being able to predict the effect of individual mutations. Certainly when Omicron came out, there are now calculators to say, hey, I don't think these monoclonals are going to do very well. And they were correct, from a guessing and then what actually came through. that it would lead to about a 30 to 40-fold difference in neutralizing titers relative to Delta. Those actually were pretty good calculations. So we're doing surprisingly well. That said, we don't have coverage of the entire genome. There's epistasis, there's multiple mutations that come along. And so it's a very tough nut to crack. And so there's still a lot of headspace and ceiling space there to go. But we've never done better. We just need more antivirals is the first thing there. And thankfully, Paxlovid, Molnupiravir, had remdesivir, we're not seeing really a lot of resistance, at least phenotypically and sort of in communities with those drugs. And so that's very thankful.
All right, please join me in thanking Alice for this fantastic